introducing our speaker for today, Dr. Joseph Pappachan. Dr. Joseph Pappachan has done his MD Internal Medicine from India, and he went on to do his FRCP and MRCP from the Royal College of Physicians in UK, and he worked in many prestigious institutions in the UK. At present, he's working as a consultant endocrinologist and physician internal medicine in the Manchester in UK. He has almost all 70 plus publications on his name, a good reputation into the academic fraternity. So we are privileged to have Dr. Joseph Pappachan today. We will hear from him in the subsequent times now. And it's an honor to have Dr. Joseph today. And he's connecting as an odd hour of the day. I believe he was talking about it's almost 10 p.m. plus in the UK. So thank you very much, Dr. Joseph. We are also privileged to have Dr. Batin Dodi from Trinidad. He's done his MD Internal Medicine. Subsequently, he has done his MRCP from Ireland and the Royal College in UK. And he has good experience as a teacher in internal medicine and cardiology. At present, he's working as a consultant physician and intervention cardiologist in the Gulfview Medical Center in Trinidad and Tobago, and also in Southern Medical Center in Trinidad and Tobago. And last but not the least, we are privileged to have Dr. Donald Gordon. He is representing the Association of General Practitioners of Jamaica. Thank you very much, Dr. Donald, for joining today. And we will start with the scientific session from greetings from Dr. Donald. Dr. Donald, please.
Good evening, everyone. Are you hearing me?
Yes, Dr. Donald.
Okay, the Association of General Practitioners of Jamaica. Very pleased to join with MSN Laboratories in hosting this update on hypertension webinar. Greetings to the MSN team and to our esteemed speaker, Dr. Pappachan, panelist, Dr. Dodi from Trinidad. We're very pleased to associate with MSN and its strong suite of products and its very motivated team of reps who come around and see our doctors. And we hope that the doctors will benefit very much from this evening's meeting. We hope the meeting will be fruitful, and the association looks forward to teaming up with the MSN team in the future in any other webinars that there might be. And we wish you all a very good meeting. Thank you.
Thank you, Dr. Gordon, very much for your greetings. And I would request Dr. Joseph to start the scientific session, please.
Good evening to all my colleagues of West Indies Islands, especially Jamaica as well as Trinidad. Thank you for giving me this opportunity to talk to you all and join you this evening to discuss management of hypertension in patients with diabetes mellitus. The world has gone through three major pandemics after the later half of 20th century. The first one being hypertension, the second diabetes, and currently the COVID-19 pandemic that affected more than 6.2 million people across the globe, and with a death toll of nearly 0.38 million by now. I'm glad to see that Jamaica has done wonderfully well with the COVID pandemic, with only less than 600 individuals affected and only 9 deaths, while in the UK, we have approached nearly 40,000 as of today. Connecting the three pandemics, COVID-19 patients have higher risk of morbidity and mortality if they have associated hypertension and diabetes. And I'm going to that talk, before which this is my competing interest statement. I don't have any thing to declare in relation to this talk or any other academic activities I get involved in. In the next 40 minutes or so, I will just quickly go through the epidemiological aspects of hypertension and diabetes, some broad aspects of the pathophysiology of the disease, through some of the major clinical trials showing benefit or lack of benefit of management of these major illnesses, diabetes and hypertension, and also an update on the current international guidelines, after which I will just give 4 clinical scenarios for a multiple choice type of discussion. And after conclusion, we can have a sharing of knowledge between you and me so that I also can learn something from this webinar. It's slightly annoying to talk to the computer in the evening without seeing all of you, but for the sake of social distancing, we have to be away from each other, especially with the COVID-19 pandemic. The relationship between COVID-19 and diabetes mellitus and hypertension. We can see that around 3.36 times higher death rates if someone has hypertension in COVID infection. And the relative risk for mortality in patients with diabetes mellitus is 2.12 compared to a non-diabetic individual. And those with cardiovascular disorders have a high mortality with an odds ratio of 2.93. Therefore, it is very important to discuss these 2 pandemics which have been there over the past few decades, taking a huge death toll across the globe. This is the recent update of the International Diabetes Federation on the Diabetes Atlas, showing a prevalence of 463 million across the globe, which is expected to increase exponentially within the next few years, making the prevalence about 700 million by the year 2045. Although diabetes is considered as a disease of affluence, you can see even in the African continent, the prevalence and incidence is fast increasing with exponential rate of 143% by the year 2045, reaching 47 million affected in Africa alone. However, a significant chunk of patients with diabetes mellitus are not diagnosed, although they have the disease. And you can see even in the US, India, China, and many other nations, the prevalence is quite high, but many of the individuals are not even diagnosed. If you look at the healthcare expenditure in relation to diabetes management, you can see USA and the Western Europe spends around $5,000 per capita an year for diabetes and its complication alone. Jamaica as well as the West Indies Islands have slightly better profile, but somewhere between $1,000 and $5,000 per year. Diabetes mellitus was identified as a coronary artery disease equivalent by the later half of 1990s, and American Heart Association declared that diabetes mellitus is equivalent to heart attack. It's a vasculopathy involving all the blood vessels in the body, causing increased cardiovascular mortality with a odds ratio of 4.56 when compared to a non-diabetic individual. Similarly, the risk of stroke is 2.5 to 4.5 times higher, and the risk of lower extremity amputations is about 30 times higher. We have recently published the data of a long-term follow-up of lower limb amputations in diabetic individuals that showed a survival less than 28% at the 10-year of follow-up. Diabetes basically is a very high risk for cardiovascular disease, and the cause of death in 80% of diabetic population is from vascular disease, of which 30% of mortality occurs within the 5 years of diagnosis, and heart disease related to diabetes alone costs more than 5.5 billion in the UK alone, with more than 20,000 deaths per year in patients with heart disease and diabetes, that is about 15% of the ischemic heart disease deaths. As I have mentioned, it's a vasculopathy which involves the microvasculature, causing retinopathy in 21%, nephropathy in 18%, erectile dysfunction, peripheral neuropathy in significant proportion of patients at any point of time. Similarly, the macrovascular disease occurs in 7% of people with cerebrovascular disease, 18% having ischemic heart disease at any point of time, and intermittent claudication in 4.5%. However, the most common associated disease is hypertension. That makes the importance of the topic today. You can see associated medical conditions in patients with diabetes exponentially increases the cardiovascular mortality with one comorbidity alone, about 59% compared to 12% in patients without the comorbidity. And these comorbidities are smoking, dyslipidemia, and hypertension, with further increase with each additional comorbidity. We have very good medications to control dyslipidemia, and that risk is hugely treated by appropriate management of dyslipidemia in diabetics. We have good number of medications for management of hypertension. And if the patient decides to stop smoking, that risk also is taken off. However, if you look at the major clinical trials, looking at type 1 diabetes, such as DCCT and EDIC trials, you can see the mortality and morbidity benefit do not change much with intensive diabetes management, at least for the first 10 years. After a decade, you may find some change in the mortality risk in patients treated intensively. However, if you look at the type 2 diabetes clinical trials, the advanced trial did not show much of benefit in intensive control of type 2 diabetes compared to non-diabetic, compared to the less intense treatment group. And the ACCORD trial, in fact, showed increased mortality if we control diabetes very tightly. This means we need to look at other risk factors for cardiovascular mortality in diabetes, especially hypertension, which has already affected 1.13 billion population, that is around 1/4 to 1/5 of the global population, as per the latest WHO update in 2019. However, you can see that only 1 in 5 individuals with hypertension get the problem under full control, and hypertension is a major cause of premature death, mainly from cardiovascular disorders. Although WHO has planned to bring down the prevalence of hypertension by 25% by the year 2025, as early as 2010, I'm skeptical about the achievement of this goal. The country of Usain Bolt is not behind, probably slightly in front in terms of the prevalence of diabetes, with 11.9% of individuals affected. And you can see the death toll in a small population like just above 2.9 million. The death rate is quite high, out of 10,000, as you can see in the figures. The UKPDS 36 study has clearly shown benefit of control of systolic blood pressure by 10 millimeters. That improves cardiovascular mortality in diabetic patients by around 15%. Reduction of blood pressure also improves the micro as well as macrovascular outcomes in diabetes. You can see in this graph, sorry about the lack of clarity of one of the graphs, there's a 24% risk reduction if we tightly control blood pressure in patients with diabetes compared to those who have less rigorous control. Looking at the mechanisms of blood pressure control in the human body, you can see neural mechanisms, renal, hormonal, as well as local mechanisms controlling blood pressure in a normal human body, of which The most important mechanism is the renin, aldosterone, angiotensin system, which hereafter I will mention, RAAS. And you can see the physiological mechanisms of blood pressure control in human body with RAAS. Kidney, especially the juxtaglomerular apparatus, secretes renin when there is decreased renal perfusion. And this renin converts angiotensinogen to angiotensin 1, which in turn get converted to angiotensin 2 by the effect of angiotensin convertase enzyme secreted from the lungs and kidneys. Angiotensin 2 is a very powerful vasoactive substance, increasing the sympathetic activity, increasing the tubular sodium and chloride reabsorption and water retention. It causes secretion of aldosterone from the adrenal cortex. This is a very powerful vasoconstrictor substance causing arteriolar vasoconstriction, increasing blood pressure, and it stimulates the pituitary gland to secrete ADH that in turn increases the intravascular volume by reabsorption of water from the kidneys. Effectively, all this increases the intravascular blood volume that negatively feedback the kidneys, reducing the renin secretion. This is the normal physiological mechanism. In diabetic individuals, RAAS is grossly abnormal, and that causes most of the pathophysiological consequences of diabetes mellitus. Therefore, we have to look at the manipulation of the RAAS, why it is important. You can see from various clinical trials that new onset diabetes mellitus may be less in patients with hypertension treated by these kind of medications. These medications reduce the albuminuria in diabetic kidney disease by alteration of the glomerular filtration pressure. They also were found to be reducing cardiovascular morbidity and mortality in various clinical trials. This is the graphical representation of the glomerular apparatus. You can see the afferent arteriole, and the glomerulus. Vasodilatory substances such as prostaglandins increases the caliber of afferent arteriole, increasing the renal blood flow. And this is affected by NSAIDs that can cause kidney disease. And vasoconstrictory substances are mainly angiotensin 2 and norepinephrine, which preferentially causes constriction of the efferent arteriole, which increases the glomerular blood pressure. And that in turn increases the GFR. And as you know, the earliest involvement of diabetic kidneys by hyperfiltration, and the angiotensin 2 alteration will help the diabetic kidney disease, which you can see from the graphical representation here, that this is a normal afferent arteriole, the Bowman's capsule and the capillaries, glomerular capillaries, and the efferent arteriole. AC inhibitors increases the decreases the vascular resistance in the efferent arteriole, increasing the renal blood flow and also reducing glomerular pressure, reducing the filtration pressure. This can be sometimes counterproductive, as most of you must know. ARBs also have the similar effect, improving the glomerular dynamics. We have different hypertension guidelines over the past few decades. The latest one was JNC 8, proposed in 2014. That has been updated by the American College of Cardiology and American Heart Association in 2017, with subsequent update of the European guidelines and the NICE guidelines of the UK in 2019. There are some similarities and occasional discrepancies between these guidelines. And you can see Americans specifically focus on the 10-year cardiovascular risk, more than 10% to rigorously control hypertension, whereas the Europeans do not look into that rigorously. Attention to the specific ethnic and racial groups, maybe because USA is a multi-ethnic, multiracial population in the American guidelines, whereas the Europeans do not look into that. However, the Europeans look into rigorous BP reduction less than 120/70, because the side effect profile in recent clinical trials were much higher if you reduce the levels less than 120/70. We have to adopt a ABCD approach in classifying the antihypertensive drugs to better understand the classes. For example, A stands for AC inhibitors, ARBs, and alpha blockers. B stands for beta blockers with different generations, as you can see in the slide. C stands for calcium channel blockers. There are two groups, non-dihydropyridine compounds such as verapamil and diltiazem, and the dihydropyridine compounds. D stands for diuretics of different subgroups, and also for direct renin inhibitor aliskiren. I will focus a little bit more on ARBs today because of their peculiar hemodynamics in relation to diabetes kidney as well as management of diabetic hypertensives. These molecules give reasonable control of hypertension in diabetics in up to 50% of people achieving the therapeutic goals, at least in the initial phase of the disease. They have excellent tolerability. They are found to reduce the progression of hypertension as well as diabetes-related kidney diseases. The long-term efficacy is slightly better than the AC inhibitors because of the peculiar ACE escape phenomenon in long-standing hypertension treated by AC inhibitors. Because, as I have mentioned in the past, the angiotensin convertase enzyme inhibits the conversion of angiotensin 1 to angiotensin 2, and long-term inhibition may result in alternate pathways to come up, such as cardiac kinase, which may also convert angiotensin 1 to angiotensin 2, increasing the effective level of angiotensin 2. This is prevented by the ARBs, and therefore ARBs may be slightly better for such patients having ACE escape phenomenon. There are several head-to-head clinical trials showing benefits of ARBs. The first few ARBs were approved by the US FDA even prior to 2000. And losartan was the first molecule approved in 1995 for various indications, as you can see, with subsequent introduction of valsartan, irbesartan, candesartan, olmesartan, and telmisartan, with latest addition being asilsartan. Telmisartan being in the market for more than 2 decades, this is a comparison of the pharmacodynamics of the molecule, which you can see this is slightly better than the other sartans with round-the-clock blood pressure control, being with a half-life of 24 hours, highly protein-bound, good bioavailability, and very low renal clearance that doesn't contraindicate use even in advanced renal disease without alteration of the dosing. This is a comparison of the superiority of ARBs over ACE inhibitors, which I have already mentioned. And we have to keep in mind that angiotensin 2 has 2 types of receptors in the body, AT1 receptors as well as AT2 receptors. ARBs preferentially block the AT1 receptors and without effect on AT2 receptors that has cardioprotective properties. There is much less side effect such as cough and angioedema related to increased bradykinin levels, as AC inhibitors are kinase inhibitors as well. Therefore, when you use AC inhibitors, up to 10 to 20% of people may need to discontinue the drug because of irritant cough, which may last for longer periods. Angioedema is the other important side effect, which is much less common in patients using ARBs. Therefore, the compliance may be better. These are the list of ARBs with some of the pharmacological properties. And telmisartan may be slightly better than the other molecules in the class because they have much better AT2 blockade, may have cardioprotective properties, and alter the PPAR gamma, which may improve the carbohydrate and lipid metabolism, reduce the insulin resistance, and may have anti-atherosclerotic and anti-inflammatory properties. Therefore, Telmisartan is considered as a cardiometabolic sartan by many people. If you look at the 24-hour blood pressure control and early morning blood pressure system in human beings, you can see that most of the cardiovascular events occur in the early morning hours. Therefore, when we choose the ARBs, we may need to consider a longer acting ARB such as Telmisartan, which has very good benefit in terms of control of systolic as well as diastolic blood pressure around the clock. This is a picture from Nature Reviews showing the angiotensin 2 kinetics. And you can see H1 receptors and H2 receptors of angiotensin 2, which shows different effects of stimulation. For example, AT2-1 receptor stimulation increases the blood pressure because of the various mechanisms I have described earlier. And AT2 receptor stimulation may be protective because that reduces the blood pressure and causes some vasodilatation. Telmisartan effectively blocks the AT1 receptors, therefore stop the effect of angiotensin 2 significantly on AT1 receptors, improving the renal hemodynamics, protecting the kidney by the mechanisms described here as well as earlier. Evidence shows that for cardiovascular prevention in patients with diabetes, Telmisartan may be used as a first-line agent. In patients with atrial fibrillation, diabetes mellitus, and metabolic syndrome. They may be also protective in patients with ischemic heart disease, stroke, diabetic nephropathy, and may be helpful for patients with cognitive decline. The largest clinical trial ever reported with Telmisartan was the on-target trial with more than 25,000 participants, having equal number of patients with 3 arms, Ramipril, Telmisartan, and the combination of both. Looking at the primary outcome as cardiovascular mortality, myocardial infarctions, stroke, as well as heart failure hospitalizations. And you can see the Kaplan-Meier report showing almost equal benefit of each 3 drug groups in the trial. The conclusions of the study was that Telmisartan is as effective as Ramipril with slightly better tolerability because of less side effect profile. It's not inferior to Ramipril and have better efficacy profile in terms of patient compliance. Subgroup analysis also showed some beneficial effect in different secondary outcomes in the treatment arm with the Telmisartan. Interestingly, the combination, although expected to improve blood pressure control in a better way, the side effects were much higher and not preferred by most clinicians now. We have to adopt a syndromic approach while managing hypertension. And depending on the patient scenario, we have to tailor the appropriate antihypertensive regime. For example, ACE inhibitors and ARBs should be used for patients with diabetes, especially in presence of diabetic kidney disease, as well as established atherosclerotic cardiovascular disorders. Beta blockers are preferred in patients with atrial fibrillation, heart failure, and ischemic heart disease. Calcium channel blockers may be first choice, especially in elderly with systolic hypertension, and as a good combination for patients with ACE inhibitors and ARBs. Non-dihydropyridine CCBs such as verapamil and diltiazem may be a good alternative when ACE inhibitors and ARBs are contraindicated. Diuretics are good first-line agents for systolic hypertension, especially in younger individuals, some of the ethnic minorities, and also in presence of heart failure. However, because of the inhibitory action of thiazide type of diuretics in the pancreatic islet cells, they may increase the plasma glucose levels in diabetics. So that's an important consideration you have to take before starting this medication. And significant electrolyte abnormalities such as hyponatremia as well as hypokalemia occurs in these patients. Most patients with hypertension, you may need to add a second or even a third line agent, and more than 2/3 of patients should at least require a combination regime to control optimal hypertension targets. If you have started ACE inhibitors and ARBs already, a calcium channel blocker may be a good addition in diabetic nephropathy, whereas diuretics may be a better choice for patients with diabetes and heart failure. To conclude with the latest American 2017 guidelines, I'm not going to all the individual recommendations. I'm just showing a couple of slides from the major guidelines, which you can refer to later. Any patients with a blood pressure consistently elevated more than 130/80 with diabetes, you have to start antihypertensive treatment. That's a class 1 recommendation with level of evidence B, and for diastolic BP, it is level C evidence based on expert opinion. All the 4 subclasses of antihypertensive agents may be used as first-line agents based on class 1 as well as level of evidence A. And in patients with diabetes and hypertension, ACE inhibitors and ARBs may be considered, especially in presence of albuminuria based on class 2B recommendation and level B evidence. If you look at the ethnic groups, I'm going to this matter, especially because Jamaica has a diverse population with many Asians as well as Afro-Caribbean subgroups. And the Afro-Caribbeans classically has less effect with RAAS modulators. And therefore, you may need to consider triazide type of diuretic and calcium channel blockers as the first-line agents. Many of these patients, efficacy of the antihypertensive medications are less, so you may need to use 2 or more combinations from the very beginning. In older people, systolic blood pressure reduction has been shown to be very effective in preventing cardiovascular outcomes, especially following publication of the SPRINT trial in the recent past. And if possible, you have to control systolic blood pressure less than 130 millimeters. However, in older populations, you have to always consider the side effect profile, especially dizziness, fall tendency, etc., before you opt for this medication treatment. With that, I will conclude, and I will go into 4 different clinical scenarios with a poll option.
So at this point of time, I would recommend that we are going to have a kind of poll questions. So Stephanie, if you could put on the poll question number 1, we would give a couple of seconds for the audience to answer. And based on the answers, Dr. Pappachan could deliberate on it. Okay. So this is a question on your screen. Please answer them.
Right. This is a scenario of a type 1 diabetic more than 20 years, hypertension more than 10 years with pre-proliferative retinopathy, well managed with MDI insulin, Ramipril and atorvastatin. The blood pressure is reasonably well controlled, but there is increased protein leak, 1.6 grams per day of protein, roughly that's the calculation. This patient has been on Ramipril for longer periods, so therefore we have to switch over to Telmisartan to prevent the ACE escape phenomenon. That may improve the protein leak. Of course, there may be other causes of protein leak. The nephrologist may need to be involved, but if it is improving the protein leak significantly, that's a good evidence that patient is benefited. And as you know, increased urine ACR is a big cardiovascular risk factor, so that we have to control the protein leak from the kidney to improve the cardiovascular outcomes as well. Shall we go to the next question? Shall we go to the answer? Amlodipine is the right answer because ACE inhibitors and angiotensin II blockers may affect the developing kidneys in the fetus. So they are going to cause problem with the nephrogenesis in the baby. So you can't use that. And diuretics can cause much of electrical imbalance in the developing fetus. So amlodipine is proven to be the best option in a patient potentially becoming pregnant because she's already on multi-dose insulin injections with good control of diabetes, and she's taking folic acid for planning pregnancy. So the ideal option is amlodipine. Shall we go to the next question? Amlodipine. Okay. I'm sure this is a very common scenario you all will come across in your primary and secondary care practice. And the correct answer is Telmisartan and amlodipine because of the ethnic background. Amlodipine or a diuretic should be used in Afro-Caribbean populations because of the better beneficial effect. And this patient may need a combination, and of the combinations, best is probably Telmisartan as well as amlodipine, because patient has adverse lipid profile. If you use a thiazide type of diuretic, that may worsen the lipid profile. And to control the high blood pressure, as you all know, any antihypertensive agent on an average will reduce systolic blood pressure by only 10 millimeters of mercury and the diastolic by around 4 to 6 millimeters of mercury on an average. You may get better effect, but if you are targeting a blood pressure reduction more than 20/10 with antihypertensive regime, you have to most often opt for a combination rather than a single agent. Right. The fourth clinical scenario. I'm sorry, HFrEF is heart failure with reduced ejection fraction. So the ejection fraction is only 40%. Right. This is a peculiar situation. This long-standing type 2 diabetic. The diabetes control is reasonable. If you try to tightly control diabetes in a 65-year-old lady, you may land up with a myocardial infarction or stroke. The blood pressure control is very important, and patient is already on Telmisartan 40 milligrams daily with some protein leak, although not macroalbuminuria, but there is increased protein leak. According to our cutoff, more than 3 milligram per millimole is significant albuminuria. Right. The best change for this patient could be increasing the dose of Telmisartan to 80 milligrams and adding a diuretic, because patient has heart failure with reduced ejection fraction, and you have to give symptomatic as well as treatment benefit with a diuretic. That will give the best results. Although you can use Telmisartan and calcium channel blocker because that will protect the kidney to some extent, but because of the ejection fraction, and patient may be symptomatic, we have to probably opt for the first option. I'm sure there will be debate about this, and that's the last question for the session. Thank you.
Thank you very much, Dr. Pappachan, for your enlightening session.